Okay, so now with the challenging cases, we have 3 cases. 2 cases will be presented by me and 1 case by Dr. Umar. So our first case, she's 48 years old, single female with she presented with right loin pain and frank hematuria. Her past medical surgical history was unremarkable. On examination, she was afebrile, normal breathing pattern, tachycardia, and normotensive. Abdomen, there was palpable right-sided abdominal mass. Labs-wise, her complete blood count were within normal limits. Hemoglobin was 11.5 gram, platelet was normal, renal function, liver function was normal. Imaging, chest X-ray shows some scattered lung lesion, and she did a CT urography as part of her hematuria workup. So this is the different cuts of the CT urography. So the report of the CT urography show right heterogeneous lobulated renal mass with area of necrosis. It measured about 17 centimeter, compressing and displacing the IVC with right renal vein invasion. There was a small hepatic focal lesion in segment segment 4A, and it's 1.2 centimeter by 1.6. There was a right para-aortic lymph node of 5 centimeter. There was a small splenic lesion, and there was multiple right lung nodule. The largest was 2.8 by 2.5. So what is the next step? Is it biopsy, cytoreductive nephrectomy, biopsy neoadjuvant and reassess, biopsy neoadjuvant, then nephrectomy as cytoreductive? So the floor is used for the panel, whoever would like to start.
It seems this is a metastatic kidney cancer with high volume. For that, I think there's a change in the way we approach those. I think I will go with option 4, which is a biopsy, systemic therapy reassessment, and then maybe later on a cytoreductive nephrectomy.
I totally agree. I don't think that surgery at this patient, there is no role for surgery at this patient. We have to proceed first with a biopsy just to confirm it's clear cell, and if any neoadjuvants, there is systematic therapy that could be given to the patient.
Yeah, I totally agree with my panel members. I think the word neoadjuvant is entirely wrong in this situation. This is metastatic disease, so systemic therapy, yeah, conventional palliative systemic therapy is what I would say.
I would agree. So it's not a low-risk metastatic cancer, but she has hematuria and pain, so she's symptomatic, but having no anemia, having a good hemoglobin, so I would go with option 14.
Just a comment, a comment on the hematuria factor. I mean, it does depend if it's intractable hematuria that she's really struggling from. You have to choose your systemic agent well. If you're looking at double IO agents, often it takes a long time for them to see regression, particularly with renal vein tumor thrombus. So it may be that a TKI plus IO or single agent TKI may work quicker. So there are other options in that systemic, when we say systemic.
Chairman, sir, with your permission, please allow me a comment. So this is a case clearly of metastatic renal cancer, and when we start this discussion, of course, renal biopsy is the first thing to do, but without risk stratification, we should not choose to comment on any of the treatments, even if it is TKI plus IO or IOI. So risk stratification after biopsy, I think, should be the first step. And beyond that, you never know, this may turn out to be a favorable intermediate risk where you still have an option of surgery which exists. You never know. Though this looks like a theoretical point, but we have to risk stratify this patient.
Okay.
I respectfully disagree with you. I think definitely the indication is for systemic treatment. Let me tell you, when we were fellows and young faculty, we would be very heroic with those cases. We used to do them, start with surgery, believing that we can do miracles. The problem is not the technical resectability. I think you can remove, if you are well trained, like doctor, you can do it. But the problem with those patients, they do very poorly after surgery. Some of them do not even recover from the surgery. They stay in the hospital for 2-3 weeks, and then you move them to the hospice. Even if their performance status initially was good, even if they are young, this is already advanced metastatic cases. I think starting with surgery.
No, sir, I am not suggesting surgery at all. I am saying that we should do a biopsy, risk stratify, then only on an academic forum. I am not at all suggesting a surgery.
So even if she has moderate risk, you still go with the same protocol.
Sir, we don't know. The biopsy may be sarcomatoid. We might be talking about something else altogether. I'm sorry.
So the histopathology, after we go with renal mass biopsy, that is the leading point for this case. So it came with undifferentiated malignant tumor. It was positive for the following marker of pan-CK, WT1, PAX8, and CD56, and was negative marker for the mentioned markers. And the histopathological impression came with Wilms tumor in adults. So the literature mentioned the adult Wilms tumor, but there is no consensus of what treatment. Mainly the literature go through that, applying the same protocol for pediatric to adult. So if it is Wilms tumor now, what is the situation? What is next, the panel opinion?
I think one of the good options is giving chemo, systematic chemo, and observe. If the patient would benefit, then we might go and resect. Because if the patient doesn't improve with chemo, then it's metastatic. Another thing, the patient is presenting with a metastatic disease. He's not locally advanced per se. It's a metastatic. So we have to treat him systematic. And if all the systematic disease disappears, then we might consider consolidation nephrectomy or whatsoever. If any of the others.
So anybody been through these Wilms in adults and their future and the prognostic things?
I think, yeah, we've seen a couple of cases of Wilms, adult Wilms. They're usually, it's difficult to predict. You're absolutely right. I think you've got to, if they're not in a non-metastatic setting, in a young patient with a large tumor, and you're suspecting something doesn't feel right, something's growing too quickly out of proportion, you've had 2 serial scans, almost exploded, get a biopsy, see what it is. In the metastatic setting, I think before anyone gives systemic therapy anyway, you should have a biopsy, regardless.
In your cases, the expected survival, although the literature, there's a few cases here and there, but so there's no consensus. But overall, at least in your experience, do they do well after chemo? Do they need further things? At least in the few cases.
Yeah, so in the 2 cases that I've been involved in, they didn't do very well in the adult Wilms patients. No, the one was metastatic, one was localized.
Okay.
Even the localized adults don't do very well. So the chemotherapeutic regime remains the same. The presentation is either late in the second decade or
Or early in the 3rd decade. There is a definite role for radiotherapy in these patients.
I see. We'll go to the second case. Yes, Dr. Adam.
I'm sorry, I want to discuss the case according to our circumstances in Kuwait. The benefit of this panel to help us. I know this is a standard, maybe international. Paris, we have a problem here in having a biopsy. Is it finding a needle aspiration biopsy or is it a trocar biopsy? Both, they have different results sometimes. Before going to the second step of knowing the histopathology, in such case, why don't go for renal artery embolization, get the tumor out, and then you can have a good time to screen the case and then to give chemotherapy because she's young, she's 40 and she's bleeding. That means the tumor is invading the collecting system. For how long you want to wait? Is this option wrong?
I don't think this option is wrong, but I don't think it's the standard right now. We used to do it all the time. The problem is, in this lady, she has high volume metastasis. If she had only isolated, even in the good performance classes, then the fact she has lung metastasis, she has multiple large lymph node metastasis, you remove the primary and you leave a good amount of cancer inside her. I used to do it all the time in the US. They don't, I have seen it, they become very sick after surgery, especially if you do embolization first. And they might stay for weeks and weeks in the hospital, and eventually they might move from the hospital to hospice because they cannot make it because their body is already consumed by that amount of cancer they have. So yes, you can do it, but will it benefit the patient? Maybe, I doubt. I mean, that's a problem in this particular case.
I would like to add one comment on this. Like the issue with these cases is understanding the cancer pathology. Cancer is not what we see as usual. Like, it's not that lesion or that metastatic lesion. Once you have a metastatic lesion, then there is a lot of cells, cancer cells are like spreading beyond that we cannot see yet. They are spreading, they are there, but it's all a matter of time to show and pick up. So if the patient goes for surgery, not systematic therapy, the patient might benefit locally, but still there is a lot of malignant metastatic disease that we didn't treat yet. So would the patient in general benefit? No. This is the
I agree. If the patient is in severe pain or intractable hematuria, which was not the case, then yes, I agree with you. If this patient is continuously bleeding and she is in severe pain, and then yes, we'll do embolization, do nephrectomy, but keeping in mind that she will have a stormy course of after surgery and she might not even make it. But in this particular patient, this is not the case. But yes, pain, hematuria, intractable, then yes, we can go for cytoreductive immediately, of course.
Okay, so we'll move to the next case. We have another female, 37 years old, married female. She just landed from 2 hours flight, and we've been notified, and the ER been notified, and patient shifted by ambulance from the airport directly to the ER. She came with a left loin pain. At time of arrival, she was in shock. She was afebrile, tachycardic, pale, and hypotensive. Her past medical surgical history was unremarkable. She was resuscitated, an ICU admission, initial lab show leukocytosis, hemoglobin of 4.8, platelet count 280, and ANR was 1.2, renal function, liver function was within normal limit. Blood transfusion and urgent imaging done after initial stabilization. So these are different cut of the CT abdomen with contrast. So the report mentioned that there is a large left renal lesion of 19 centimeter with acute hemorrhage and active bleeding, and hemorrhagic intra-abdominal and pelvic free fluid with radiological impression of angiomyolipoma. So what is next? Is it like conservative angioembolization, urgent nephrectomy, or any other suggestion?
If it was in my opinion, I would go for angioembolization plus nephrectomy.
If you have access to angioembolization, you should do it urgently. If not, I think you should go for urgent nephrectomy.
It all just depends on how this pans out. So if resuscitation is adequate, patient is stable, your embolization suite is ready and the experience is good in these acute setting, then the embolization is the first point to call. If you've got an unstable patient that's not responding to fluid resuscitation, then they might need an urgent nephrectomy. There's always a presumption that things are AMLs. Sometimes you don't know what's bled, but it's most likely.
I will definitely avoid urgent nephrectomy by all means on this patient. unless you do angioembolization first, very well, completely, even if you embolize the whole kidney, and still the patient is hypotensive or still bleeding, despite that, then you consider it as the last resort, because those patients, if you go open them immediately, there's very risk they can collapse on the table and they cannot make it. So angioembolization, of course, and you stabilize the patient, then you wait, because if you repeat that scan maybe in 3 months or so, if it's AML, you might be surprised. It might be much easier to do any surgery later on, and you might even avoid the surgery completely if it's only AML.
Okay. So we have the privilege of angio suite. Patients were selectively embolized. So there was a selective left renal angioembolization. Post-embolization, patient clinical course. She has a persistent high-grade fever, shortness of breath, and tachypnea with progressive pleural effusion that was tapped, tachycardia, normotensive. So what is next?
I think this is what you expect from embolization. This is the systemic reaction to it. Even if you do it selectively, I will just give her hydration, anti-inflammatory if her creatinine is good, and just wait on her.
Typical post-embolization syndrome. So if we could re-image in 48 hours, just to have a sense of what's happening, as she's a bit of tachycardic, and repeat her labs to make sure that she's not going to bleeding again or anemia.
Wouldn't you check for pulmonary embolization?
Of course, you have to keep it in mind. You have to keep that she is having progressive pleural effusion that needs to be observed. You have to do serial hemoglobin on her every 6 hours to make sure that she is not continuously bleeding. But from the data I have, that's very expected after embolization.
Okay, so we deal with the case initially that it is post-angioembolization syndrome, that the fever, but the patient was symptomatic for quite long time. So re-imaging were considered, and this is after the embolization, like after 10 days of the angioembolization, 10 days patient was in the hospital with persistent. We're thinking about any other superimpose of necrosis and abscesses, formation, whatever. So it was imaged. Again, this is the status post-angioembolization. So the report say that there is, sorry, maybe the report is not there, but anyway, it was the area of necrosis is shown more in this study. So patient went left challenging open nephrectomy because of persistent fever, persistent pain. Post-nephrectomy patient, still, she has persistent high-grade fever, shortness of breath, tachypnea, with progressive, that time become like almost bilateral pleural effusion. So we go with the PCD that time, not tapping only. She was tachycardia, normotensive. So we're thinking about, is it AML? Would we buy it as an AML or it is something else? So we label her as malignancy until we see the pathology. So, and this is what really came of surprise, that it was a chromophobe renal cell carcinoma with renal sinus fat extension. Post-embolization, there was extensive necrosis in the specimen. There was negative surgical margin. So this takes us off the fat poor AML that with its differential diagnosis of cancer. So would we buy AML as first diagnosis as 19 centimeter in such cases? Do we see frequent AML with this size, or with these sizes we should always consider malignancy background?
Of course, whenever you have a bleeding tumor, you have to keep malignancy in mind. This is basically, I think in this particular cases, diagnosing AML in the setting of acute bleeding is very, very difficult, because you have blood everywhere, you have mixed tissues of perinephric fat mixed with the blood. So I think it's maybe over stating if you call it AML immediately. So any bleeding tumor, you have to keep it in mind, but AML can bleed, can give similar presentation. I think you did a great job by doing a aggressive open nephrectomy. Probably if you have waited a little bit more, the surgery would be much easier.
Yeah, of course.
But I congratulate you for doing it.
No, I agree. I think, you know, even if you looked at this case again, and you would probably think AML again first. I think the important thing here is that if, say, everything had settled down and there was no problem, the most important thing is that you re-image these patients at an interval after the bleed, because that is when you're going to decide whether something looks like an AML in retrospect, or is it really a renal tumor. So don't just embolize and leave these patients and they never come back. It's the follow-up that's actually important.
So as the panel, do you have any consensus in follow-up post-angio embolization for AML? Is there like a cut point when to do the follow-up CT? And what if it's not shrinking? Like we are out of the cancer, if it is AML?
I typically will do the CT scan 3 months after surgery if it's AML. If the tumor still look the same, if it's more than 4 centimeter and did not shrink after embolization, then I have to, you know, consult and consent the patient for a partial nephrectomy, of course, no radical in this case, or versus close observation. And so I think both options will be acceptable.
Putting them on everolimus is also a good option. When they are on surveillance, 10 milligrams of everolimus every day, that is the only drug which has some kind of level of evidence in AML. And especially when their tumors are really 3 or 4 or 5 spread across the kidney, and you do selective embolization of few of them. You obviously cannot embolize all of them, and these are not clearly amenable for partial nephrectomy. These patients do well on everolimus, 10 milligrams every day.
The issue with diagnosing these AMLs, the only problem is we are diagnosing them only by imaging. We are not doing like biopsy. We don't biopsy these. So taking this step forward, giving them systematic therapy based on radiographic appearance only, I think it's like, despite there is approved trials talking about everolimus.
But this case is difficult to diagnose on imaging, but otherwise imaging is really 100% correct. You have systemic, there may be cutaneous stigmata,
yeah.
so on and so forth.
I take your point on the everolimus. I think the problem is if you were convinced that this was an AML and there was multiple AMLs, or you're looking at a TS syndrome, then yes, okay, maybe everolimus. The problem in this case is that if you give everolimus, it's an AML and there's some shrinkage. If it was a renal cancer, there may be some shrinkage as well. It makes it you're still in the conundrum at 3 months, aren't you?
Yeah, this case there's no question of everolimus. We are talking about follow-up.
Yeah,
This case you are not able to visualize the tumor on the person. So as the panel said, I would absolutely agree. Re-imaging is the first thing.
So let's just change the question. Like we usually angio-embolize anything above 4 centimeter. So is there like a cut limit for the bigger size? Would you think that angio-embolization will work for 12, 10, 14? There is like no agreed consensus on these. So as upfront, for most of you are a famous robotic surgeon with a lot of cases, would you grasp the angio-embolization as a solution for at least these above 10 centimeter AML?
I think it still remains a solution, a part of your armamentarium. Just because there are bigger tumors doesn't mean it's just a more difficult angioembolization. You may need to coil 1 or 2 more vessels.
No, in sense of treating the disease, would these patients get benefit of angioembolization for AML above 10? Above 10 centimeter.
We angioembolize
you saw
over,
such
over
cases.
10,
Nice,
yeah,
nice.
yeah, for sure. I mean, it's just like, is it easier to do a 4 centimeter partial or a 10 centimeter partial that's exfil? They're still they're going to be difficult, but they're still doable. And embolization does just offer you that little bit of breathing space, and it's less invasive for that individual as a first solution.
I mean, I just have my reservation against that option because first, when you do the CT scan with the arterial phase, not AML look the same. Some AML are very vascular and others are like mostly fat. So, and if embolize a 10 centimeter AML that's not bleeding as elective embolization, you are going to deal with the best embolization and make the patient sick. So it's not as straightforward as it is. I personally favor partial nephrectomy on those big tumors if they are in good location, especially, you know, and I have done 8, 9 centimeter, 10 centimeter partial. Those are usually not as difficult as doing a partial on a RCC, especially if they are fat mostly containing partials, and you don't have to worry much about violation, the margins and all that stuff. So yes, I personally favor robotic partial on over embolization.
I see. Dr. Umar, you can now present your case.